First, I would like to thank my dear Professor Amal Bishlawi for inviting me to share in this wonderful conference. And it's my honor and pleasure to share this great session with eminent professor and eminent speaker and eminent chairperson, and many thank Dr. Ahmed for introductions. I will talk about one of the problems faced in our pediatric patients. طبعا الدكتور علي طاهر سهل المشكلة خالص. هتكلم إن شاء الله على thalassemia and cancer risk and challenges. I will start first by very brief overview on the iron overload and thalassemia, and then I will present 4 cases of thalassemia developed malignancy, and finally conclusion. Beta thalassemia, as we all know, it is the most common hereditary anemia, and it is most commonly found in the Mediterranean descent, in addition to Africa and Middle East. About 80 and to 90 million carrier worldwide. What about in Egypt? The study done by Professor El-Bishlawi found that the carrier rate range from 5 to 9%. We made very important multi-center study in 5 universities in Tanta, Sharqiya, Munufiyya, Dahliya, Mansoura, and Alexandria, and to detect the carrier rate in the secondary school children's on 4,320. We found the overall carrier rate about 6.1%, with the highest incidence in Sharqiya and the lowest incidence in Munufiyya. This work is published for publications. So thalassemia syndrome, as we all know, characterized by spectrum of clinical presentation ranging from just mild anemia in thalassemia minor to moderate anemia in thalassemia intermediate to severe anemia with frequent blood transfusion in thalassemia major. And this pathophysiology discussed several times today, but the most important sequelae of thalassemia is the iron overload, which is responsible for most of the serious complications. So how iron overload can lead to toxicity? As Professor Amal said in the morning, we have 70% of the transferrin unsaturated to act as a buffer against any increase in the iron. But if the transferrin saturation is saturated, non-transferrin bound iron was formed, which is the dangerous and toxic. So we say what happened in the normal condition. ده الميكانيزم الرباني اللي ربنا سبحانه وتعالى عمله لنا علشان الايرن توكسيستي. احنا عندنا الترانسفيرين ان الايرن بيخش inside the cell according to the cellular need. We have transferrin receptor in the surface, and according to the expression, the cellular need, the iron enter. So there is no increase in this toxic intracellular labile iron, either stored or functional iron. But what happened with non-transferrin bound iron? It enters in the cell in uncontrolled fashion. So when it exceeds the synthetic capacity of ferritin, it will lead to increase the free radical, which is highly toxic and can react with any macrocellular molecule. So increased labile iron will lead to increased intracellular labile iron, formation of reactive oxygen species, activations of the apoptosis pathway leading to cell death, DNA damage, genomic instability and neoplasm, and also to lipid peroxidations, which later leads to fibrosis. So the end of this iron toxicity is cell death with all oocyte and neoplasm and fibrosis. So how iron toxicity can lead to cancer? At the molecular level, excess iron is genotoxic. It can lead to DNA damage. This DNA damage can cause mutation of the tumor suppressor gene. One of the most important is B53, as we all know, it is a guardian of the genome, and also mutation of the DNA repair. There is also evidence indicates that both angiogenesis and metastasis influenced by this increase in the reactive oxygen species. In addition, iron overload or iron toxicity modulates the activity of several transcriptional factors, including NF-kappa B. Overexpression of NF-kappa B upregulates the interleukin-6, which leads to chronic inflammation and cancer. In addition, spectrum of immune dysfunction can occur with iron toxicity. Iron toxicity or iron overload adversely affects the macrophage. It inhibits the tumoricidal activity of macrophage. In addition, it was found also to decrease the surveillance of cancer cell, in addition to abnormalities in the T cell. It increased the number and activity of suppressor CD8 and decreased the number and of activity of CD4 cell. Others, iron facilitate inflammation, induce the neoplastic transformation, and also iron is essential for proliferating neoplastic cells like any cell in the body. So I will start by one of our cases. This is 11 years old, the net of consanguineous marriage at 1 year, diagnosed as thalassemia based on the hemoglobin electrophoresis and molecular study. The child unfortunately non-compliant to iron chelations. At the age of 9 years and 6 months, she developed recurrent attack of high fever, severe pallor, and increased transfusion requirement. The child cannot withstand 1 week without transfusion. On examination, you have severe pallor, tachycardia, arthritis, huge splenomegaly, so the patient is admitted. CBC, white cell count, 3500, hemoglobin 6, and platelet 13. So we have a case of pancytopenia with huge splenomegaly, pallor, arthritis. Liver function test, just mild elevation, ferritin is very high, virology all negative except hepatitis C, echocardiography impaired left ventricular function. The patient given the spheroids, platelet, and also RBCs transfusions and start to complain of headache. MRI, there is bilateral subdural hematoma. So what we do? The patient given nearly twice daily platelet and nearly every other day bagged red cell transfusion. So we do bone marrow. And what we found? Infiltrations by 94% plus cell. Immune phenotype was done and positive for TDT, CD79, CD10, 10 and 19 and 20, so the diagnosis of common ALL. So attention please, the symptom of malignancy, this like anemia, fatigue, splenomegaly can be overlooked in the patient with thalassemia and considered as a complication. This patient admitted for correction, the condition for splenectomy because of this very huge spleen and pancytopenia. And this case is published in Hemoglobin. Another case, this girl, 15 years, diagnosed as thalassemia intermedia, also based on the hemoglobin electrophoresis and molecular. She was on hydroxyurea, supportive therapy, and infrequent blood transfusion, splenectomy done at 10 years. At the age of 15, she developed generalized bone ache, abdominal pain, persistent fever, and dyspnea. On admission, she is pale, tachypnea, tachycardia, and hepatomegaly. Laboratory investigations هنا surprise النقيض hyperleukocytosis. الوايت سيل كاونت كانت 250,000. Serum electrolyte nearly normal except platelet. All virology abnormal. Abdominal ultrasonography reveal hepatomegaly with calcular cholecystitis and bilateral diffuse enlargement of the kidney. Bone marrow reveal 80% infiltration with blast cell and immune phenotype also with common LL and co-expression of CD13 and CD33, and this case also is published in 2020. So is there is relation between beta thalassemia and acute leukemia? This study discussed by Professor Ali Tahir, but I will, through this study, 5 pediatric patients develop malignancy. Hematological malignancy, 2 cases of Hodgkin lymphoma, the age of the child can from 10 and 6, and 2 cases of acute lymphoblastic leukemia and 1 case of acute myeloid leukemia. 2 of the cases of acute leukemia كانوا thalassemia intermedia, 1 case كانت thalassemia major. وده طبعا الاستادي اللي هي published in Taiwan but only in the adult. ده ريفيو عندنا 5 cases of acute lymphoblastic leukemia in thalassemia major. So is there is risk of developing leukemia in thalassemia? The answer is yes, and this is discussed by Professor Ali Tahir either through iron overload or through transmission of oncogenic virus like Epstein-Barr virus, cytomegalovirus, or through DNA, through hydroxyurea as it interferes with the DNA synthesis and repair, and also in the case of thalassemia intermedia, overactive bone marrow can lead to fault in the DNA repair and later on malignancy. Case 3, 11 years old girl diagnosed as beta thalassemia intermedia at the age of 4 years. She was on hydroxyurea and other supportive therapy and regular chelation therapy. The patient with well control with defrazorex, serum ferritin can 800 nanogram per deciliter. At the age of 11 years, she developed unsteady gait, weakness, headache, and drowsiness. طفلة جت كان عندها unsteady gait, drowsy, and head. So, all electrolytes, مفيش history, no history of trauma, of fever, of drug intake, or any other system. All electrolyte, blood sugars, everything is normal. So, we do MRI and MRV. MRI reveal well-defined space-occupying lesion in the bones extending to the midbrain. MRV was normal, so the diagnosis was diffuse brain stem glioma. The fourth case is 39 years old man on regular blood transfusion, splenectomy at 15 years. At the age of 39, she developed abdominal discomfort. This is a CBC of the patients, just anemia, virology, all virology are normal. There is increase in the alpha fetoprotein, increase in the CA19, and carcinoembryonic antigen is normal. Liver enzymes increase in the total bilirubin, both direct and indirect. Mild elevation in the liver enzyme, serum ferritin also is high, and mild prolongation of prothrombin. CT was done and revealed enlarged cirrhotic liver with well-defined focal lesion in segment 5 of liver. And the most also another important finding, enlarged head of pancreas with calcifications. This is the MRI. This is the hemosiderosis of the liver. As we all know, the liver is the most important site of iron storage. About 79% of stored iron in the liver. So CT-guided core biopsy was done, and the result is hepatocellular carcinoma grade 2 with widespread cirrhosis and widespread cirrhosis and evidence of cirrhosis. So liver can be affected, markedly affected with thalassemia, either through iron overload with all pathogenesis of iron overload, or through cirrhosis, which is the triggering of hepatocellular carcinoma, and this can occur either by hepatitis B or hepatitis C infections. So hepatocellular carcinoma is growing cause of premature morbidity and mortality among thalassemia. Effective chelation therapy and treatment of hepatitis C virus infection are needed to prevent complication and reduce the mortality. And also it is very important to do screening every 6 months. So my conclusion, excitance of malignancy and beta thalassemia is not rare. The true role of iron overload in malignancy in the patient with thalassemia require further investigation. The most important message is to alarm the physician. Two, if there is worsening of anemia, worsening of fever, or splenomegaly, or bone ache, are alarming to look for leukemia or other hematological malignancy. And thank you.